The second session is sponsored by Pfizer's Limited Inflammation Division and Zydus Biovation. Now may I request our chairpersons for the second session, Dr. K.M. Mahendranath, to come on the stage. Dr. Mahendranath is one of the senior most consultant rheumatologists in our country since 1984. He has done diploma in tropical medicine and health from Liverpool, UK, and FRCP from London, UK. He has received various prestigious awards and has published various papers in national and international journals. Now I request our second chairperson, Dr. Vijay K.R. Rao, to come on the stage. Consultant at Manipal Hospital, Bangalore. He has done MRCP Rheumatology from London, CCT in Rheumatology from UK, post-CCT fellowship in SLE and rheumatologic disease in pregnancy from UK. He has published over 10 publications. Now I request our esteemed chairpersons to lead the session. And one more announcement. I hope you all have registered your name at the entrance. At the end, we will be having one lucky draw session and prizes will be given to 2 lucky persons. Now I request our chairpersons to lead the session. Thank you.
Give me this opportunity to chair this wonderful session. So we're going to have 3 wonderful talks. The first one is from Dr. Vinod Ravindran about leflunomide. The second one is about use of DMARDs in special situations and precautions. And the third one is DMARDs and beyond by Dr. Arvind Chopra. So the first session, to introduce the speaker, I would like to call upon Dr. Vinod Ravindran on stage. So it gives me a great pleasure to introduce him. So he is a senior consultant rheumatologist and has his own center of rheumatology in Kerala. So he has got his FRCP Edinburgh in 2011, MRCP UK Rheumatology in 2010. In addition, he has MSc Rheumatology from University of London, UK. He's done his MD Medicine in University of Rajasthan, Jaipur, India, and MBBS from University of Indore. He is a member of BSR UK, IRA, Association of Physicians India. He is a fellow of RCP UK. So he has worked in as a consultant rheumatologist in National Hospital Kozhikode and currently has his own center of rheumatology in Kerala. He has got various publications to his credit. He's got quite a lot of academic work to his credit. He's been the editor-in-chief of Indian Journal of Rheumatology, associate editor of Indian Journal of Rheumatology, and to several other journals. He is the reviewer of Rheumatology Oxford, BMJ, Journal of Rheumatology, Lupus, Clinical Rheumatology. It's quite hard, Vinod, to actually introduce you. I'm struggling to read your CV. So I would actually say he's a very esteemed speaker, and I'll leave the floor to him to kindly give us some insights on leflunomide. Thank you.
Thank you. Thank you, Chase. Good afternoon. At the outset, I would like to thank my dear friend Chandrasekhara for this invitation. And I have waited for 4 years for this to actually be realized. There was some confusion about the names, and then there was some confusions about the places. But ultimately it was figured out actually Vinod Ravindran is only one, and he lives in Calicut, and he is a rheumatologist. He's not a radiologist, he is not Chandran, and he is not based in Canada. So by the time we figured out, it was 2015. So here am I. So, all right. And these are my disclosures. You might have your own, but this is the reason way back in '89 I chose medicine. So let's move on. It's rare nowadays to get 30 minutes in any rheumatology conference to get to talk to. But this is an important topic. Rheumatoid arthritis, as speakers before me have already alluded to, is an autoimmune inflammatory process, and it has the potential to damage the joint by having these unwanted cells or processes taking place inside the joint, which is affected by this disease process. Tremendous disease burden. Whatever figures you look at, I would say they are fairly conservative. The disease goes beyond the joint and it affects quality of life. It affects the person's ability to work. It affects the person to ability to work to the degree he has been trained to do, and it leads to a reduction in the income to the tune of 1/4 compared to the person who does not have the disease, and it does translate into a lot of cost to the society in taking care of patients who have rheumatoid arthritis. And as it was already pointed out by Dr. Chandrasekhara, that the damage to the joints starts very early in the disease process. It just depends on what type of method you use to pick this up. So what I'm going to do, even at the cost of repeating myself and definitely repeating the speakers before me, I'm going to utilize the time allotted to me by discussing two concepts and one drug. So I mean, and it's really, I think, good to note that both Dr. Chandrasekhara and Dr. Dharmanand have actually alluded to these concepts, but I think it is important to go through them all over again. And to start by saying that any joint affected by rheumatoid arthritis, because this is the prototype disease we are discussing, it goes affected by the disease, it goes under a process of repair and damage, but ultimately the reparative mechanisms fail and the joint is not able to do what it was supposed to do, like weight bearing, doing fine tasks, doing difficult or complex tasks. And as the time goes by, you have more and more damage setting in. So window of opportunity is where you can address or intervene and thereby maximize the potential benefit to your patients. So if you look at this, if you start your treatment here, this damage would have already set in. Whereas if you start the treatment here, there is much less damage occurred, so that the benefit is much more to the patient. And this is again saying the same thing in a different way, that the damage related loss to the function remains. So it is key, absolutely imperative to actually reduce the damage to allow to happen. Early arthritis, if you look at the older classification criteria, a lot of things as like radiographic changes, it actually denotes established disease. Whereas the focus nowadays is to pick up early disease. And how do you pick up early arthritis? So forget about lots and lots of symmetrical hand arthritis. If you have more or 3 or more swollen joints, think about rheumatoid arthritis. Even if there are no swelling, if you squeeze the MCPs and MTPs, you can think about there being arthritis. Don't wait for arthritis to be causing early morning stiffness of more than 1 hour. Some degree of early morning stiffness can also should be able to raise your suspicion. And also if it is supported by elevated inflammatory markers and positive serology, it is very helpful. The new classification criteria, as has been already told, are not without its limitations, but they are actually quite useful in actually telling us to start thinking about a group of patients as having rheumatoid arthritis, even before radiographic damage has set in, even before the disease duration has been for 6 months or so, because these points are not here at all. And these campaigns actually talk about these important thing, which is early arthritis. Like this is an old APLAR campaign. This is a campaign which is running still in UK. If you have 3 years, think about there being early arthritis, and consult your doctor. Poor prognostic factors, it was alluded in one particular slide where, so these are the poor prognostic features. Signs of active disease, if they have lots and lots of swollen joints, high inflammatory markers, if they had disability to begin with, if they have high, especially high levels of rheumatoid factor and anti-CCP antibodies, these are actually poor prognostic markers. And also if they have extra-articular manifestations. So these are the extra-articular manifestations, and lots of them. If patients have extra-articular manifestations, they are twice as likely to die of cardiovascular morbidity associated with rheumatoid arthritis compared to them who do not have. And this is the list of extra-articular manifestations. So in your patients, newly diagnosed patients at rheumatoid arthritis, if they have these features, involvement of nerves, pleura, pericardium, eye, this puts them at a higher risk of having disease-associated damage. So when we start to treat these patients with disease-modifying drugs, whether it is biological or conventional, we should be addressing all the three domains of the disease. One is the disease activity itself, and other is the damage-related aspects, which is mainly functional, and the disability, which can also happen because of the joint damage, but also because of the social or psychological issues surrounding the ability to enjoy good health. So what is treat to target? It is there in every field. To give you an analogy with the cardiovascular medicine, in hypertension we know that a good control over the blood pressure is always better, and in the dyslipidemia management we know that if we have total cholesterol and LDL to as low as possible, it is always better. So treat to target in rheumatoid arthritis is to check the status of the patient, adjust your treatment according to the goals you have in your mind, and try to achieve that goal. So what are these goals? So if you really look at it, we only have one goal, which is remission. So it is the total absence of any signs and symptoms of disease in an individual patient, which you can reckon that would be difficult to achieve. So we got a surrogate goal, which is called low disease activity, which is, you can say it's a fair compromise, and it is a pragmatic and practical compromise to achieve in our patients with rheumatoid arthritis. And again, just to sum this up, in dyslipidemia versus rheumatoid arthritis, we know that statin more effective than placebo. So treating rheumatoid arthritis is always better than not treating, and then combination is always better than monotherapy. We know that aggressive statin therapy is actually better than the lenient statin therapy, as if you don't give any treatment at all to the treatment you should be giving, and rheumatoid arthritis, same is true. Risk is lowest with the LDL cholesterol is lowest, and again, if there is no disease activity, there is no damage. So stating the obvious is that early aggressive treatment with combination of disease modifying anti-rheumatic agents, keeping in mind a target, is always better for your patients. So this is again has been highlighted. So you use some type of measure. I mean, there are several. I think a student has already done this wonderful piece of research comparing DAS28 versus CDAI versus RAPID-3. There are several different tools to, if this is the most commonly used tool, if your patients achieve a disease activity score based on 28 joints to less than 2.6, it's very good. Anything above 5.1 is very bad, and 5.1 to 3.2, we still need to do a lot. And as I said, there are several different things. We'll not go into the detail. It is absolutely important to have a target. If there is no target, what you are shooting at. So this is again taken from one of the well-accepted guidelines. When you are facing a patient with active rheumatoid arthritis, there can be only two outcomes you should have in your mind. One is to achieve remission, which should be sustained, or you should be able to achieve low disease activity, which should also be sustained. This is important because when you start treating patients with rheumatoid arthritis with your disease modifying drugs, within 6 months you are able to make out, provided your treatment has been goal driven, that which patients are not going to ever achieve remission or ever achieve low disease activity. So by 6 months you can actually separate a group of patients who are not going to be benefited by your conventional disease modifying drugs. So probably I think Professor Chopra is going to talk about this when he does that. Couple of examples to highlight that why goal driven treatment is much more effective. You can see that this is research we did. The primary endpoint was actually education, but what you can see here, the group, both the groups, we had target ULR good response in mind, and we used step down combination therapy with glucocorticoids. They had monthly review of everything including the disease activity, and the disease duration was early, less than 1 year, and you can see that a lot of patients in both groups were able to achieve remission and low disease activity. So the point is, if you have a target, you can achieve it, or at least you can try to achieve it. Similarly, this is from Dr. Malviya in Delhi. He uses a computer-aided objectified, which a lot of us actually do. If there is a target, you can achieve it. And that's why it's absolutely important to have a target. Now, so having discussed two concepts in brief, let me talk about the drugs. If we have a lot of immunologists sitting here, so just to keep it very simple, at the very, very basic level, probably in a single patient, individual patient with rheumatoid arthritis, you might have two different type of immune systems, which might be primarily responsible for the onset of rheumatoid arthritis, which could be B cell or the T cell. All the treatments we have target one of these or more. Dr. Rao's name was mentioned. So these are the drugs we have currently available. There are few more, but what is most important is not the drug, including the drug I am going to talk about, which is here, which is fairly recent one in 1991, but these pivotal trials which have told us that what should be our approach when we treat a patient with rheumatoid arthritis. So it's not about the drugs, it's about how the drugs are used. So as was mentioned in Dr. Chandrasekhara's inaugural session, that by our ability now or our awareness now to use the older drugs in a better way has been the key recognition or awareness as far as rheumatoid arthritis management is concerned, not the drugs which are listed in this far right end, which is biologics. So you have a lot of non-biological disease modifying drugs, and we love them all: sulfasalazine, gold, methotrexate, leflunomide. And then we have biological agents. We have more as we talk, being developed as we talk. So really, to come to the leflunomide in last part of my talk is to be able to actually say that unlike many other drugs, right from methotrexate to sulfasalazine and other drugs, leflunomide stands out right from the beginning because as opposed to the drugs being tested in the test tube first, this was a drug which was tested first on the animal models. And its unique property is to inhibit this dihydrotate dehydrogenase and thereby inhibit the pyrimidine synthesis. You can see here. So it disrupts the pyrimidine pools, and you have various sort of multifactorial outcome as a result of the inhibition of DHOADH by leflunomide. And linked to that is actually to be able to interfere with the T cell monocyte interactions and lead to an inhibitory effect on these interleukins and TNFs in a patient who has rheumatoid arthritis or other type of autoimmune inflammatory disorders. There are some other secondary modes of mechanism of actions which you can read here, and these are sort of not the primary mechanism of actions, but they do help in individual patients. So, coming to rheumatoid arthritis, its key indication is, I would say it's two. It's not that leflunomide is not used as a monotherapy or as the first up therapy in the management of rheumatoid arthritis, but mostly you would see that it is used as an add-on to methotrexate when methotrexate in a sufficient dose is not able to do the job. And secondly, if the patients have not been able to tolerate methotrexate, probably because of the GI, or even when you have switched the methotrexate to the subcutaneous route, then leflunomide can be tried. So either as a monotherapy or as a replacement for methotrexate when it has not worked, or as a addition to methotrexate where methotrexate has not been fully effective. These are the three sort of indications in leflunomide in rheumatoid arthritis, but it's not that much used, at least in my practice, as a monotherapy. But there are other indications. Psoriatic arthritis, there is robust evidence that it is actually effective in psoriatic arthritis. So rheumatoid arthritis and psoriatic arthritis is mighty effective. It's been used in almost all the rheumatological conditions because it is an immunomodulator. So wherever we are sort of short of options, its name will come up somewhere. So it has been used in vagus, it's been used in PAN, it's been used in non-renal lupus, so that is the skin and articular manifestations. It's been used in spondyloarthritis, very similar to how it is used in how the sulfasalazine or methotrexate is used in ANG-SPOND, and also is being used in JIA, and the list is endless. Sarcoidosis, you name it, it's been used. The typical dosing is 10 to 20 milligram per day. Usually it's a good practice to start with the lower dose, which is 10 milligram per day, and gradually increase. And especially if you are combining with the methotrexate, you need to be starting at the lower dose. It's a slowly acting drug, so it takes about 3 months to be fully effective. And at that time, you might have to use glucocorticoids as a bridge therapy. Loading dose was used earlier because, and this is 100 milligram to be given daily for 3 days, and then you go to 10 milligram daily dose. But it had a lot of GI side effects. So patients were put off by taking this treatment based on their experience of first 3 days. So it has actually fallen out of favor. I don't think any of us are using the loading dose. Though this strength is available for commercial purchase and use, and some companies will happily supply you this 3 days tablets course also. But it is neither used nor recommended. That is the conclusion. It has a lot of adverse effects. Initially, when leflunomide was marketed, people thought that actually it is safer than methotrexate, but that is not the case. It has a lot of GI side effects, diarrhea, and you have all the manifestations of GI intolerance, including oral ulcers, which can happen in methotrexate, to also colitis and other things. Liver toxicity is the main risk. It is a hepatotoxic drug, very much like methotrexate, and you can have range of effects leading right from mild jaundice to severe permanent hepatitis, liver necrosis, if it is neglected or remains undetected. And there could be skin manifestations. Alopecia is very important. When methotrexate is discontinued because of very, very troublesome hair loss, if they are switched to leflunomide, that risk remains. So it is not without its own effect on the hair loss, and then some other rare type of skin manifestations are also seen. Hypertension is very important here. Patient should be monitored for rise in the blood pressure. In my practice, I do it every 6 months because I could not find any sort of guidelines, but it is said that annually at least it should be checked, and most of the patients would be checked for their blood pressure and weight anyway. Myelosuppression is again a real risk, rapidly dividing cells. Remember what Dr. Dhamanan said. So when it comes to monitoring, the baseline investigations are very similar to what Dr. Dhamanan has already suggested for methotrexate. Very similar to methotrexate, you would be monitoring these patients by minimally at least doing SGPT and complete blood count at baseline, and then doing it monthly, and once the dose has been stable, then probably once every 2 months after 6 months. And if you are using leflunomide in a combination with a drug like methotrexate, then of course it needs to be more frequently and you need to exert more caution. Contraindications are very similar to other immunosuppressants. Avoid this in any severe immunodeficiency. If patient has serious infections, liver problem already, renal impairment moderate to severe, and if there is any evidence of pre-existing myelosuppression, it is best not to use it, or if absolutely pushed to do it, use it with great caution. Unlike other drugs, there is a very specific sort of thing about leflunomide in pregnancy. So in women who have childbearing potential, they need to be thoroughly cautioned and counseled. And it is prudent not to actually use this drug in women of childbearing age when the pregnancy is excluded, and then counseled and emphasized on the use of using reliable contraception, and making them aware about the serious risk to the fetus if they get pregnant while taking leflunomide. And if they do become pregnant, again, they need to be cautioned, counseled about the risk to the fetus, and they should have this drug elimination procedure. So why it is important that the metabolites of leflunomide, which have the teratogenic potential, they can remain, it will take about 2 years for them to come down to an acceptable level. So unless the drug is eliminated by using cholestyramine, that is again for 11 days, 3 times, 8 grams, 3 times a day, this is oral dose, this level is not going to reach below what is considered to be acceptable and safe for the fetus. So this is very important. And again, if you ever come across this situation, most of the companies who make leflunomide, they are able to offer this service for you free of cost, but this has got a serious implication. And males, there is no data that they should be, it has got any teratogenic potential from the male side, but in the absence of any studies or any recommendations, it is actually prudent to actually ask them to discontinue leflunomide well before time, which is going to be 2 years, or use the cholestyramine elimination procedure if required. Coming to the lungs, again, this is methotrexate, we know that is actually causes a lot of lung toxicity. So when the leflunomide came, the lot of long-term and short-term trial data actually did suggest that actually safer for lungs. And so the myth started. But right after the drug was marketed, there were reports of interstitial pneumonitis, and there were further reports of tuberculosis reactivation, pulmonary abscesses, extra-articular tuberculosis, extrapulmonary tuberculosis, and the CSM UK in these first 6 years reported about 17 cases of acute interstitial lung disease. 5 of them were fatal. So it was actually considered that the drug is not as safe as it was originally thought based on the clinical trial data, but it is much more toxic. And this cavitating pneumonia, I mean, who thought that leflunomide can cause cavitating pneumonia. So this is a case series of 5 patients published in 2007 in Rheumatology, where 5 patients who were taking methotrexate developed cavitating pneumonia, and I'll show you some pictures. And we came across a case in 2009, 2010, where a person who had rheumatoid arthritis with absolutely remarkable control over his rheumatoid arthritis with leflunomide 20 milligram per day, no other drugs, continued to have this very high ESR and CRP. Blue is the CRP and the red one is the ESR. And to cut the long story short, chest X-ray, what do you see? Right. So there is a big cavity on the left apex. So I think it's useful to go through this list of cavitating lung lesions and add leflunomide here. This is the patient you can see on the CT, very big cavity. We gave the antibiotics. This was purely sort of empirical therapy based on some previous sort of sputum examination which was done 3 years ago. Only very barely minimum improvement in the follow-up CT after a year. And this is the second case we had come across of leflunomide causing cavitating pneumonia. So 5 plus 2 is 7 basically. So this we reported much earlier. So the point is, leflunomide or drugs like leflunomide, even I would say methotrexate and all the other mycophenolate mofetil, they all have the propensity to cause serious infections or serious adverse events, which mean we may not be able to pick up unless we are extra cautious about them. And these are the 2 postulated mechanisms how leflunomide can cause actually cavitating pneumonia or indirectly contribute to its development. So to conclude, and then I'll take 2 more minutes, leflunomide is an extremely important drug in the current armamentarium available to treat rheumatoid arthritis and many other autoimmune rheumatic manifestations or diseases. But it's not safe, and it's definitely not safer compared to methotrexate, so we had to do away with that sort of feeling of false assurance. And the unusual infections can run a protracted clinical course, and we may be not able to pick them up unless we are extra careful. In India, when the leflunomide came, there was a lot of unethical promotion about its safety. People were using it for 15-20 days like anti-inflammatory agents, and I would caution and request all of you to use your awareness based on this talk not to use it indiscriminately. And you don't need to know German, nor do I, to tell you that use this with great caution. So that concludes the talk. And it's my immense pleasure to invite you all to the next South Zone conference of the Indian Rheumatology Association, which is going to be held at the end of February, Sunday and Saturday at Calicut, Kerala, North Kerala. And we have these 2 wonderful international faculties, really the world leaders in their respective fields. And we have, for the postgraduates and the students, UGs, PGs, we have 2 workshops on scientific writing. Remember Dr. Shankar was mentioning, and he is one of the faculty in that, how to write paper. Doing good research is not enough. It has to be written well to get accepted in leading journals. And also and workshop on basic immunology, which would be of interest to many of you, I hope. And we have case presentation. If does not satisfy you, you can submit case reports, and there are exciting prizes associated with that also. So I would really like to thank you for your kind attention. And before that, this is one more quiz. Anybody knows what is this? I put it here. But why put the name Arava here? So Arava is the brand name of Sanofi, who actually were involved in the drug development of leflunomide. And strangely, the word alawa in Hebrew means willow. Now, so we got two famous arawas now. One is arawa leflunomide, which is a globally accepted brand of leflunomide by Sanofi. But this is an actually what is called a short takeoff and landing carrier made by the Israeli engineers. And it's a fairly sort of stout-looking aircraft, can carry about 25 armed forces in their full gear. And this was launched way back in 1969. So I don't know how sort of Sanofi came to acquire the word Arawa, but this is, in the military circles, this is actually more famous for that. Thank you very much.
Thank you, Dr. Vinod, for such a lovely and enlightening talk and making us aware of the serious side effects of leflunomide. Now, in the interest of time, both myself and my co-chair have decided we'll take questions after the next two talks.